Hey everyone, and welcome to This Explainer. Look, if you're gearing up for your nursing boards, you already know spinal cord injuries are a massive, highly tested topic. Today, we are distilling this whole complex subject down into the 20 hallmark points you absolutely need to know to pass your ATI and completely ace your exams. Let's dive right in.
Okay, I want you to picture this for a second. A patient with a T6 injury suddenly develops a pounding headache, their face is totally flushed, and they have a terrifying blood pressure of 210/120. Do you know what this complication is? More importantly, do you know your absolute first nursing priority? Well, by the end of this explainer, we're going to break down exactly how to handle this classic, high-stakes scenario so you can basically answer it in your sleep. To keep everything efficient, we've broken this down into 5 quick sections today: anatomy of the spine, types of spinal injuries, acute effects and shock, the autonomic dysreflexia emergency, and finally, nursing care and rehab. Let's start right at the top with Section 1, anatomy of the spine. So, normal spinal function really just comes down to 3 main things: an intact cord, good blood supply, and the bony support of our 33 vertebrae. That's 7 cervical, 12 thoracic, 5 lumbar, 5 sacral, and 4 coccygeal. It's kind of like a suit of biological armor protecting some incredibly delicate wiring inside, specifically that inner H-shaped gray matter and the white matter tracts around it. In this system, sensory information travels up to the brain and motor commands travel down. If there is a disruption anywhere in there, you're going to see dysfunction.
All right, time for your first homework ATI points. Point 1, you have to know the spinal thalamic tract. This is your ascending tract, and it carries pain and temperature sensation. Point 2, the cortical spinal tract. This is your descending motor tract, which controls voluntary action. Seriously, if you just memorize these 2 tracts, you can easily figure out a patient's symptoms just based on exactly where their cord got compromised.
Moving right along to Section 2, types of spinal injuries.
How do these injuries actually happen? Usually, it's the result of abnormal, violent physical forces causing severe trauma to the cord. Think about hyperflexion. We see this a lot in head-on car crashes where the neck is just violently whipped forward. Then you have hyperextension, which is like hitting your chin on a steering wheel and bending the neck way too far back. And finally, compression. This often happens from a vertical fall, where the vertebrae physically crush down on each other, literally sending bone fragments right into the cord.
And that brings us to hallmark points 3 through 6. Point 3, the cervical spine is incredibly vulnerable. Why? Because it lacks the restriction of the ribs, making it the most frequently injured area by far. Point 4, a complete injury means exactly what it sounds like: a total, absolute loss of motor and sensory function below the lesion. Point 5, an incomplete injury means there's a partial transection, so some variable function actually remains. And point 6, please highlight this one in your brain, it's an absolute favorite on nursing boards: Brown-Séquard syndrome. This happens when exactly half the cord is damaged. The patient will have same-side motor loss, but opposite-side loss of pain and temperature.
Okay, on to Section 3, acute effects and shock. What are our immediate priorities when the body goes into crisis?
You really need to lock in hallmark points 7 through 10 right now. Point 7, any injury at or above C5 is a massive respiratory emergency. That's because the phrenic nerve, which controls the diaphragm, gets interrupted, which leads us right to point 8. Injuries at C1 to C4 absolutely require immediate mechanical ventilation. Point 9, when you are securing that airway, you must exclusively use the jaw thrust method. Never, ever tilt the head back, or you risk slicing the cord even further. Finally, point 10, during the acute phase, giving high doses of the steroid methylprednisolone within the first 8 hours can reduce swelling and actually help preserve cord function.
Homework point 11 is a classic trap for students, distinguishing between 2 major nervous system complications. First up is spinal shock. This happens immediately after the injury. It's a temporary response where reflex activity below the injury just completely shuts down. The paralysis is flaccid, zero muscle tone. This can last for days or even months, and you'll know it's finally resolving when involuntary, spastic movements start returning. So contrast that temporary flaccid state with our next major topic.
Section 4, autonomic dysreflexia. Pay incredibly close attention here, guys. This is one of the most heavily tested, life-threatening emergencies you'll see. Because this right here is hallmark point 12. Autonomic dysreflexia is a wildly exaggerated sympathetic nervous system response, and it occurs exclusively in patients with injuries at or above the T6 level. What sets it off? A noxious stimulus anywhere below the injury. Most of the time, it's a distended bladder, but it could literally be severe constipation or even just a tight blanket. Since the cord is severed, the brain's calming parasympathetic signals can't travel down to fix the issue. The result? Massive unchecked vasoconstriction below the injury.
We're talking dangerous hypertension, like up to 300 systolic, bradycardia, and a severe pounding headache.
So, going back to that exact scenario from the beginning of this explainer, here are your life-saving hallmark points 13 through 16. Point 13, your absolute first action is to elevate the head of the bed to 45 degrees. Let gravity help drop that dangerous blood pressure immediately. Point 14, hunt for the trigger. Always check the bladder first. Look for a kinked catheter or do a straight cath. Point 15, if the bladder is completely empty, check for fecal impaction. But, and this is a huge exam trap, you must apply a topical anesthetic before digital disimpaction. If you don't, the pain stimulus will actually make the dysreflexia worse. And point 16, if the blood pressure is still critically high after you fix the cause, administer the ordered antihypertensives.
All right, that brings us to Section 5, nursing care and rehab. Once they are stabilized, it's all about long-term management. Hallmark point 17 is all about mastering functional milestones. ATI loves testing what a patient can actually do based on their lesion level. For instance, a C4 injury, they're going to be dependent on a ventilator. But if you move down to C7, the patient has enough intact muscle function to manage a specially equipped manual wheelchair. Go down to T6, and they have full control of their upper extremities, meaning they can be completely independent in their activities of daily living. You have to know this to set realistic nursing goals. Now, to actually stabilize the cervical spine and stop further damage, physical devices are often used. Gardner-Wells tongs are literally inserted into the skull for skeletal traction, whereas a halo vest actually allows a paralyzed patient to be moved out of bed. The crucial nursing point for both of these? Meticulous pin site care. You have to clean those pins twice daily with sterile saline to prevent infection and watch out for any purulent drainage. Oh, and a golden rule for the halo. Never, ever use the halo ring to physically pull or turn the patient. Just don't do it.
For surgery and immobility, we've got hallmark point 18. Always log roll the patient as a single, straight unit when you're changing their position. You need a minimum of 3 nurses for this, and 1 nurse is dedicated exclusively to holding the head and neck. If they've had a laminectomy, keep a close eye on that surgical dressing. Any clear drainage could indicate a dangerous cerebrospinal fluid leak, and you need to report that instantly. Hallmark 19 is aggressively preventing the hazards of immobility. Put on those sequential compression devices to prevent DVTs, and rigorously check for pressure injuries, especially on the sacrum, since the patient won't be able to feel the skin breaking down.
And finally, Hallmark point 20, long-term management. Success here is all about strict routines. Bladder retraining often involves intermittently clamping and releasing the catheter to build up tone. A strict bowel program with scheduled times and a high-fiber diet is absolutely mandatory to prevent the constipation that triggers autonomic dysreflexia. You also have to monitor their temperature closely. These patients often develop poikilothermia. They lose the ability to sweat or shiver below the lesion, meaning they essentially take on the temperature of the room, kind of like a reptile. Lastly, address altered sexual function with open, honest communication, and support them through their massive psychological shift from shock to acceptance. Look at this quote: "Rehabilitation begins at admission." Our job as nurses isn't just to save the spinal cord in the ER, it's to set up the foundation for their highest possible quality of life from day one. By mastering these 20 hallmark points, you aren't just going to pass your ATI boards, you are going to be an amazing advocate for your patients. So I'll leave you with this. When you walk into your shift tomorrow and your T6 patient suddenly complains of a pounding headache, will you know exactly how to save their life? Thanks for hanging out with me for this explainer. Keep studying hard, and I'll see you in the next one.